So there is a mechanism which just avoid this damage or which just help you, like which helps right during some damage. So it's basically your hemostasis. So how do it helps? Okay, so we have basically two kind of hemostasis. One is primary and other is secondary. What's your primary hemostasis? Like it's a normal thing, you guys must know that. For example, if you have an endothelial damage, so the first cells which are going to come and which are going to form the plug initially are your platelets, right?
Yes.
So platelets are going to come first. They are going to just cover that damaged area and okay, then after some time what happens, you are going to see fibrin coming in to this platelets plug, and it would be just strengthening it, right? So platelets, whenever it comes and it just like avoid the damage process in order to form a plug, it's your primary hemostasis. And whenever the fibrin come and it stabilizes that complex, so it's basically example of your secondary hemostasis. So in primary hemostasis you are going to see platelets moving towards the site of damage. In secondary hemostasis you are basically strengthening that platelet plug simply. So how do we strengthen that? With fibrin. Okay, how do the fibrin come? You know, you are going to see activation of coagulation cascade. Okay, that is related to PT and PTT, if you guys remember. So whenever we discuss pathologies associated with primary hemostasis, that is some of the pathologies of platelets, so in that case your PT and PTT won't be affected, because here we are just dealing with the primary hemostasis. The secondary haven't started till yet. Simply, you can just simply think of. So you guys must know that. Okay, so what happens in primary hemostasis? Let's do it in a little detail. Okay, for example, if we have a damage, what's the first thing which we are going to see here? For example, we have endothelial damage.
There's a vasoconstriction.
Okay, perfect. Like if we have damage, so this vessel is going to vasoconstrict, or it's like it would just try to close that deficit. Okay, just give me a second. Okay, for example, if you have any kind of damage here, so this vessel is going to vasoconstrict. Okay, so can you just tell me that vasoconstrictive mediators, what would be that? That are
Endothelin.
basically
Endothelin.
endothelin. Perfect. Endothelin. Okay. Right after that, you are going to see platelets coming here, right?
Yes.
But before that, okay, so we need endothelial exposure. Yes. Once they are damaged, the endothelial is exposed. But before the platelets attach to the surface, you have a molecule that come in between. What's the name of that?
Von
One
Willebrand
Willebrand
test.
Willebrand factor.
Okay, perfect. Von Willebrand factor. Perfect. Von Willebrand factor. Can you just tell me von Willebrand factor is present in a certain body, is very high yield. You are going to see an MCQ related to that. What's the name of that?
granules,
Weibel palate.
Weibel palette.
Okay, it's Weibull palette bodies. And you know, basically, the von Willebrand factor helps some of your coagulation can cascade, one of your factor inside your coagulation cascade.
8.
And what's the, okay, perfect, factor 8. And what's the significance of it? We'll be seeing it while we study the hemophilia A or
Yes.
hemophilia A. Okay. So here we will be discussing their close association with one another. Okay, so von Willebrand factor is going to attach here via a receptor. What's the name of that? High yield.
Glycoprotein 1B.
Okay, GP1, 1B. Okay, once after the von Willebrand factor is attached, then what happens? You're going to see platelets attaching to them, right?
Yes.
Yeah.
Okay. So once the platelets is attached, platelet is going to attract more platelets, right?
Mm-hmm.
Yes.
That would be attracting more platelets. How it's going to release some mediators? Can you just name some of the mediators?
It-
Okay, perfect. ADP.
Thromboxane A2.
Okay, thromboxane A2. Okay, so you guys now. Okay, serotonin. Perfect. Okay, and they are basically present in which granules? Alpha granules, I guess, right?
Yes.
Yeah.
Also granules.
Okay. Okay. So, for example, if we just put an individual on antiplatelets therapy, let's suppose if we have increased chances of which we'll be studying, that is, let's suppose DVT. We are going to, okay, let's suppose AFib. So we are going to, like, you know the idea. For example, if I am giving a drug which is inhibiting thromboxane A2, what does it mean? It won't release these mediator which attract more platelets. So what's the name of that drug?
Aspirin.
COX 1
Perfect.
2 inhibitors, NSAIDs or
Aspirin,
aspirin.
COX, one inhibitor. Okay. So these platelets are going to attract more platelets, and these platelets are going to be adhered with one another. For example, this. Okay, let me draw it here. Okay, for example, this is my platelet. It's attached with one valent factor, and it's going to attract more platelets. And platelets to platelets adhesion take place via receptor. They have a receptor in between them. You're going to see
2B3A.
fibrin in between them. And what's the name of those receptor which attaches platelets with platelets?
2B3A.
Perfect. That's GP 2B
2B3A.
3A simply. Okay. Okay, we were discussing a condition. For example, if a person is having CKD, there in cardio module we discussed, you are going to see increased uremia, right?
Yes.
Yes.
Okay, increased uremia is going to give you pericarditis, right?
Yeah.
Okay, along with pericarditis, there I told you it's also going to inhibit platelets to platelets adhesion, if you guys remember.
Yeah.
Yes.
Okay, you might have seen an MCQs in your world related to it, a person having CKD, right? Have you guys seen that MCQ?
Yes.
Okay, so basically uremia also decreases this platelets to platelets adhesion with one another simply. Okay, so now for example, okay, one general thing which you guys must remember, for example, if a person is having some deficiency with primary hemostasis, that is platelets, so you are going to see bleeding which would be associated with some super, it would be superficial or deep bleeding. What do you think?
Superficial.
Superficial, perfect. And for example, if a person is having some deficiency with those factors or secondary, so you're going to see bleeding as well. What would be that? It would be
Deep bleeding
super,
or joint
Deep.
bleeding.
Due to
deep
secondary.
joint bleeding. Perfect. Like in case of hemophilia A, we would be seeing deep bleeds, right? Okay. So first of all, we are going to discuss a condition, and here we are going to discuss a higher thing. Okay. For example, if a person is having a condition that is ITP, first of all, let's break this name. What happens in ITP? I stand for immune.
Immune.
T stands for
Thrombocytopenia.
thrombocytopenia. What do we mean by thrombocytopenia? That
Low platelets count.
your platelets is decreasing. If your platelets is decreasing, it means you are going to see bleeding, right?
Yes, superficial.
Okay.
Yes.
And it would be superficial, like it may be in the skin. So, for example, the skin bleeding, it can be also called as purpura. Okay, can you guys tell me the difference between the ecchymosis, petechia, and purpura?
Petechia
Size
1
difference.
bits.
Okay, the only difference is the size. So
Yes.
purpura is like greater in size. Okay, like that's I think it's around or
More
greater
than
than
1
one
centimeter.
centimeter. One
Ecchymosis
centimeter.
is the largest one, and then
No,
purpura
purpura.
and petechiae.
Yes, ecchymosis is largest one. Yes, it is greater than 3 millimeter, and purpura I guess is greater than 1 centimeter.
And
No,
petechiae is
no,
the smaller
purpura.
one.
Purpura the
Purpura is the
biggest.
largest.
Yeah,
Purpura
the
is the
largest.
biggest.
Yes.
Don't confuse me, doctor, please. Okay. Purpura is the biggest. Look, I have told you I believe you guys. It doesn't mean that you'll be confusing me. Okay. So Purpura is the biggest one.
Okay.
Okay. So it means, like, only just see the name, you have some immune problems which is going to cause some decreasing in it's going to decrease your platelets, and whenever you have less platelets you are going to see superficial bleed, that is skin bleed, and it causes purpura. Simple. Okay, you guys also know. Okay, so in immunity we already studied that immunoglobulins just tag your, okay, for example, it would tag your pathogens. Okay, and what
Mm.
would happen, it would just present it to some cells in order to destroy it simply. So the same phenomena is going in this case as well. Your IgG is going to come, IgG is going to be attached to your platelets,
Antigens.
okay, as an antigen, and platelets would be just uh, okay, and these antigen antibody are they are going to go into the spleen, and ultimately they would be destroyed because you are marking the platelets for destruction, right? So it is the overall idea of immune thrombocytopenic purpura. Hello.
Yes.
Okay. So guys, remember we have already discussed in immunity that almost half of your antibodies are made inside your spleen,
Yes.
right? And this spleen can
Bioplasmas.
basically like make these auto antibodies IgG. They would attach to spleen. So we have discussed one of the condition. If you guys remember, what happens in hereditary spherocytosis? Hello. You guys are already done with anemias. Please tell me what happens in hereditary spherocytosis.
Loss of biconcave shape.
Okay, in hereditary spherocytosis, you know some of the ankyrin and band 3 are basically lost. So what happens? The biconcave shape is basically like the shape, like now it would be in a shape of sphere, and this sphere is going to go into your spleen, and spleen is going to eat it simply. So you will be seeing destruction of your red blood cells inside your spleen, which would cause anemia. So what was the treatment option for that? Splenectomy, right?
Yes.
Yes.
Yeah.
Just okay. So in this case, if your spleen is making your IgG, and again this IgG bound with platelets come to spleen for their destruction. So can I just remove their spleen in order to help them?
Yes.
Yeah.
Perfect. Yes, I can also. In this condition, one of the treatment option would also be splenectomy, right?
Yes.
Yes.
Okay. So, like basically, it's divided into two phases. That is some acute and chronic. Acute basically happens in children right after some viral infections. Okay, can you guys just tell me what's a normal count of platelets? Platelets count. Normal range for platelets
150K to 450.
150K to 400K.
to 400K. Okay, perfect. So, okay, in this case, your platelets is going to decrease more than 50. Whenever it decreases more than 50K, as you told. So what happens? You are going to see this is one of the hallmark of immune thrombocytopenic purpura. I have already told you. For example, if I am having any problem with your platelets, it means your secondary hemostasis isn't included in this pathology. So what would be your TT and PTT?
Normal.
Normal.
Normal, because I am not seeing any involvement of that fibrin plugs. There is only problem with the platelets. Okay, so it is very high yield. You must guys must know this that what happens in each and every condition. Okay, so there is also one of an approach, and you guys are most probably going to see an MCQs in your related to that. One of the treatment option would be giving them
IG.
IVIG. Okay, what's the idea of administration of IVIG?
Repl- uh,
Block FC receptor.
It would what would it do?
FC receptor blocking.
FC receptor.
it will
Okay.
raise platelet count.
Yes, it would raise platelets count.
Immunoglobulin.
Okay. So the idea is like it's very interesting basically. For example, this is your spleen. I would just give these individuals IV, IG. So what would your spleen do? Your spleen would just be distracted. It would leave your IgG bound to platelets, and it would start attacking or eating up IVIG. So in this case, you are basically distracting your spleen in order not to eat your platelets. So platelets would rise. Now, did you got the idea of administration of IVIG? It's
Yes.
Yeah.
only for distraction of your spleen. Your spleen is going to eat your IVIG, and they will just leave the platelets. Okay.
Okay.
So, can you guys tell me that a condition that is MAHA, microangiopathic hemolytic anemia? First of all, you guys are going to break the name. Okay, MAHA. Okay, M stand for
Micro.
Microangiopathic.
micro. A for angiopathic.
Mm.
Mm.
That is hemolytic
Anemia.
Anemia.
anemia. So micro angio stand for your small. Okay, micro for small, angio for your blood vessels, and pathic it means it's pathology of one of your small blood vessels.
Yes.
And in okay, what are you going to see in this pathology? You are going to see hemolytic
Microthrombus.
anemia,
Yes.
or your red blood cells are going to be destroyed. So what's that condition? Simply, for example, if I just form a meshwork in between these blood vessels, it means whenever the red blood cells move through them, they would be teared off. These
Yes.
meshwork or these blocking or these filters can simply tear, or it can simply break your red blood cells. If you are breaking red blood cells, so it would give you hemolytic anemia. So can you just tell me the condition in which this you are going to see increased formation of these filters or these meshworks?
TTP.
And
Okay,
Hemogenic
HUS.
syndrome. NDIC.
okay, in DIC and
HUS. Hemolytic
Embolic
uremic syndrome.
thrombocytopenic purpura hemolytic uremic syndrome.
okay in okay ITP. So basically, what happens in DIC, you are going to see. Okay, we will be discussing it. Okay, so let's discuss DIC first. Okay, so what happens in DIC? It's a pathological activation of your coagulation cascade, right? You are going to see a ton of MCQs. One of your U-World MCQ, they'll be telling you a person is having some heat stroke. Okay,
Yes.
okay. If a person is having heat stroke, it means his tissue factor. What's the tissue factor? 7 is going to be released inside your blood. Once the tissue factor released, it's going to activate your what?
Factor 7.
Okay, factor 7 is going to activate what? It's going to activate your coagulation cascade. And as a result of that, you are going to see activation of coagulation cascade or formation of these platelets and fibrins meshwork everywhere inside your body, right?
Yeah.
Yes.
So it's formed everywhere, everywhere inside your body. It means you are going to see hemolytic anemia. Why? Whenever the red blood cell cross through that meshwork, so they would just broke, they would just break. So you are going to see hemolytic anemia in DIC. Okay, what happens in what are some of the other conditions which are related to DIC? One of which, one of the MCQs which I've already told you, heat stroke can also cause DIC. You are going to see an MCQs related to it. Very high yield. Similarly, snake bite can also give you DIC
Septic shock.
because snake. Okay,
Amniotic
septic
fluid
shock can also give
embolism.
you.
Obstetric
Okay,
complications like
obstetric.
abortion.
Yes, it can also give you because from the amniotic fluid, if you release certain substances, for example, thromboplastin, it can activate your. Okay, one of the other
Coagulation.
condition, if you guys remember, in leukemia.
Yes. Malignancies.
Okay, we have ore rods. If you guys remembered, ore rods are made by the myeloperoxidase.
Yeah.
Myeloperoxidase, guys, you remember in respiratory we talk about myeloperoxidase. They are going to kill your bacteria. Green color, one of your UWorld MCQ. The greenish color of your sputum is due to increased activity of your myeloperoxidase. Did you guys remember that MCQs?
Yes.
Yes.
Okay. So myeloperoxidase can be sometime what happens, it is going to form some crystals into your blast, into the blast cells that are from your myeloid lineage. Okay, and it is one of the hallmark of differentiating your myeloid lineage from lymphoid lineage, which we will be discussing in our white blood cells module. So sometime what happens, this ore rod or this myeloperoxidase crystal can just leak off into your blood, and they can also activate your coagulation cascade. Very high yield. You are going to see an MCQs in WBC module related to this concept, right? It can also activate your what, guys? It can activate your coagulation cascade. As a result of that, you are going to see hemolytic anemia, MAHA, microangiopathic hemolytic anemia, right? DIC.
Yes.
Okay,
Yes.
so what will happen in case of DIC? Oh, your platelets is going to decrease. What happens to PT and PTT?
Increase.
Okay,
Increase.
okay. So in DIC, you're okay. So we were discussing about microangiopathic hemolytic anemia. So, okay, on the it's very high yield that on the smear you are going to see certain characteristics red blood cells. What's the name of that?
Schistocyte.
Okay, perfect. Schistocytes, or you can also say they are helmet cells.
Helmet cell. Yes.
Broken down, it's in a form of helmet. You can say, also known as helmet cells. Okay. So one of the cause of microangiopathic hemolytic anemia can be TTP. What is TTP? It's basically thrombotic thrombocytopenic purpura. Thrombotic, it means you are going to see some thrombotic events. And as a result of that thrombosis or thrombotic event, what happens to a level of platelets? They are consumed. If platelets are consumed, it means you are going to see thrombocytopenia, right?
Yes.
Mm.
Okay, and again, if you have thrombocytopenia, you will be seeing purpura, right?
Yes.
Yes.
Okay, so can you just tell me what happens in TTP basically?
Uh, Decrease the Adam TS13.
Okay, Adam TS13. So don't confuse yourself with that. Simple. When your von Willebrand factors are released, basically they are released in form of your multimers like that. Adam TS13 is going to come. It's going to break it into monomers. But sometimes what happens? Some you can see some antibodies against your Adam TS13 as well. So if I am seeing some antibodies against Adam TS13, it means Adam TS13 won't work. If it won't work, it means you are going to see multimers being released. Okay, von Willebrand factor multimers, and as a result of that, these multimers are going to increase activation of your primary hemostasis, or in other words, the platelets activity is going to be increased. So increased platelets activity means again you are going to see these meshworks, right?
Yeah.
Yes.
Okay, you are going to see hemolytic anemia as well. Why? Because one of red blood cell, helmet cells, all of the things, right? So TTP can also form it. Okay, one of very high yield. You are going to see a lot of MCQs in your U world. That is HUS. What is HUS? First of all, the bacteria, the bug which causes HUS, high yield. One of your U world MCQ.
E. coli.
E. coli. And okay, what's the name of that E. coli? That is basically that causes dysentery 0157H7.
Yes.
Okay, okay, and it can okay. How does this E. coli invades inside your body? You must know that in
Under
undercooked beef,
undercooked.
undercooked beef. Okay,
Yes.
so what would this E. coli do? Simply, it would just damage your endothelial surface. Whenever your endothelial surface is damaged, again, what happened? Platelets coming in, right? Hello.
Yes. Yes.
Yeah.
Okay, so platelets coming in again, anemia, right?
Thrombocytopenia.
Thrombocytopenia. Hemolytic.
Okay, thrombocytopenic. Okay, so you are going to see anemia as well, cystocytes. Okay, so
Yeah.
in HUS, it's hemolytic uremic syndrome. Hemolytic uremic syndrome. So you are also going to see involvement of your kidney very high yield. Vessels of your kidneys as well, right?
Yes.
Yeah.
Okay, okay. You may also be seeing some CNS abnormalities. So you guys are going to tell me what happens to the bleeding time if your platelets are consumed.
Increase.
Freeze.
Okay, what happens to a level of PET and PTT? It's all
Normal.
deal normal. Okay, we are also going to see cystocytes, right?
Yes.
Yeah.
Okay, so now let's discuss some other condition. For example, if we have genetic, okay, here we were studying about GP1B and 2B. Here, GP1B. For example, if I have genetic mutation of GP1B, what does it mean? That platelets cannot be adhered, right?
Yes.
Yeah.
Primary
Yes.
hemostasis cannot take place. Can you just name that condition, that genetic condition in which I'll be seeing
Bernard
mutation?
Sawyer.
Okay, perfect. That's Bernard Solier. One of your UWorld MCQ that you are going to see an MCQs related to it. They are going to ask you which it's basically mutation of which of your receptor, that is GP1B, right? Okay, another condition in which I'm seeing mutation of this GP3283B.
Glanzmann.
Glanzmann.
Transmits.
Okay, it's Glanzmann's thrombasthenia, right?
Yeah.
So,
Yes.
okay, now let's discuss. Okay, for example, if I'm giving a patient with antibiotic, okay, let's discuss one of the concept. For example, if I'm a person is on chronic antibiotics, okay,
Okay.
and in that kind of individual, what have I seen that okay, uh, he has some hemorrhagic disease and blood isn't stopping. Can you just relate this condition? Why does this antibiotics
This
give me
decrease
this condition?
flora, normal flora of the GI systems and that lead to vitamin K deficiency. And vitamin
Perfect. So
K
normal
dependent
flora
factors.
of GI is going to give you your potassium, right?
Yes.
Okay. If I am just diminishing his GI flora, so potassium become less. Potassium is going to help in gamma carboxylation of some of the factor. What's that?
2, 7, 9, 10.
2,
19.
7, 9,
10.
10,
10.
or 1972. Okay. So it's
Yes.
going to, okay, once your 1972 do not form, what happens? There is defect in your
Coagulation factors.
what?
Coagulation pathway.
Coagulation cascade, right?
Yeah.
If coagulation cascade is diminished, it means you won't see the formation of that fiber in the secondary hemostasis. Okay, so okay, now let's discuss another condition. Okay, guys, on the day of boot camp, we will be having an entire session, a detailed session. The boot camp would be like quite big, so you guys must attend that boot camp as well, right?
Okay.
Because I'm going to discuss a lot of things. Because now I'm just giving some time to micro as well, so most of the things inside the hematology I have just skipped them off, and we're going. I'm just planning to discuss that on the boot camp day, right? You guys must be there. Okay, so let's discuss our last pathology for today, that is hemophilia A. You guys are going to tell me what happens in hemophilia A.
Factor VIII deficiency.
Okay, or hemophilia 8. Simply remember it. You are going to see factor 8 deficiency. If I am seeing factor 8 deficiency, what happens then? Okay, if there is deficiency in the coagulation cascade, so we already discussed, would the bleeding be superficial or deep?
Deep.
Deep.
Okay, so
Amorphous.
I'll be seeing some deep joint bleeding, right?
Yeah.
Yes.
Yes.
Okay, so can you guys tell me that what happens to the level of PTT and PT?
PTT
BTT
will
will
lead
decrease.
to PT normal.
Yes.
Okay, PT is normal
APTT increased.
and PTT increase. Okay, so we are also going to discuss all of that stepwise pathway, intrinsic against extrinsic pathway. Once you know that, you can easily just identify which increases and which remain normal and which would decrease simply. So, what's the treatment option for them? Simply give them factor 8, right? And
Yes.
what would be the presenting features? You would be having some deep tissue bleeds, post surgical bleeds, right? And it's also association with your von Willebrand factor associated.
Yes.
Yes, von Willebrand factor basically. Okay, can you okay, last one. Let's discuss last one. Okay, von Willebrand factor deficiencies. Okay. So for example, if a person is having von Willebrand factor deficiency, we already know the basics. What would happen in them? We won't be seeing formation of that platelet plug, right?
Yeah.
Okay. So what happens to the bleeding time?
Increase.
Okay. So would the bleed be superficial or deep?
Superficial.
Superficial.
Okay,
But
but it's
deep.
also associated with the factor 8, right?
Yes.
Not
Initial
too much
superficial, but
bleeding, but
Yes. Not too much association, but Still
But there
we
is
can,
bleeding. Like,
but still
Yes,
they
yes,
have.
there is deep bleeding. Like if we have deficiency factor 8 in severe cases in this, we will have deep bleeding as well.
Yes, we are going to see deep bleeding. We are going to see post-surgical bleeding because your von Willebrand factor stabilizes your factor 8. They are in association with one another in weeble parallel bodies simply. So they have the association. You guys must know that. Okay. So it was all about today's lecture. Hope so you guys enjoyed, and we are going to discuss a lot on the bootcamp day. So kindly attend that boot camp. I would just suggest you to attend it live. Don't go for the recordings because it's going to help you. We are going to have an interactive session as you guys already know. So thank you guys. Hope so you guys enjoyed. Thank you.
Bootcamp is on which date, sir?
Yes. Thank you, Doctor.
Okay, once after we complete our system, let's see when are we completing. Okay, it's our third day, right?
yes.
Yes.
Hello. It's our third day. Okay, we are also going to discuss some pharmacology because pharmacology of this system is very high yield.
So
Okay.
there would be session on Sunday as well, like tomorrow and day after tomorrow as well,
Okay, so
or is
we
it us?
Saturday. Okay, on Sunday you have a catch up day. Okay, just enjoy, kick off your books. Don't worry about your studies. Okay, because you guys were just saying about you guys just did a lot of hard work last week. So I'm just planning to give you a catch up day on that. And right after the catch up day, we are going to have a boot camp.
Okay. Doctor, you
Okay.
previously, yesterday you asked, told about that Anki flashcards. So when will be that ready?
Yes, I just told you that I am uploading it and it would just take 3 to 4 days. I am working on that. So
Okay. Okay.
I'm also planning to add these pictures as well. So sorry for that. Like it's a lot of burden on me as well. But I'm trying my best. So
Okay.
you guys are going to get that. Don't worry.
Sunday means on 27th, right? 27th is a catch up day.
Yes, 27th is your catch up day.
Okay. And then 28th boot camp.
Yes, on 28th we are going to have a boot camp.
Boot camp
Okay.
for only hematology or all the system?
All the system, hematology, hemostasis, as well as white blood cells.
Okay.
Like
Okay.
whole
Boot camp
hematology.
would go for how many hours?
It would go for, I think, in this, like it's a long system, so it would go for 4 hours, I guess.
Thanks.
Okay. Thank you.
Okay. So thank you guys. And right after this system, you are going to do dermatology. Don't worry about dermatology. One of the doctor was saying that how can we complete it within 3 days. So dermatology, it's hardly 4 to 5 pages of first aid, and you have around about 120 MCQs. So don't worry about that. You already have that pace. You can just do it in a single day. So 3 days are still more than enough for your dermatology. And just guys, do your hematology. It's very high yield and one of the like a difficult kind of system. The hematology, the white blood cells. I'll just try my best to make it simple on the bootcamp and here on the daily lecture sessions. I'm also discussing those high yield points. So don't worry about that. And still, we are also going to have revision. So just follow the steps, believe, trust in the process, and in the end, you are going to achieve your goal. Okay.
Okay.
So
Doctor,
thank you guys.
Doctor, a last thing in your the question that there is a lot of genetics consequences. Can you explain them in the bootcamp?
Genetics in what?
In your the questions, there is a lot of questions about genetics.
Okay. So have you seen this MCQs in hematology?
Yes, yes, it's in.
Yes.
Okay. Okay. We are going to do the hematology related genetics. Okay. We will do that. No worries.
Okay, thank
Dr.
you.
Ahmed.
So yes,
Yeah,
Dr. Reem.
yeah, Dr. Ahmed, I just need 2 minutes. Actually, in you made one C mnemonic for that Wegener's granulomatosis.
Yes.
Yeah, can you please make that small diagram again? I forgot that.
Okay. So what happens in Wagner granulomatosis is that it's also known as, okay, That is, you can just remember of Wagner granulomatosis.
Just the
So,
symptoms.
so C stands for it's C anka, cytoplasmic C anka. Okay, so just draw a diagram. For example, this is your individual. Draw a C. So you are going to see an upper respiratory involvement, right? You are going to see involvement of your lungs and your kidneys.
Okay.
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 Yeah.
So
Yeah.
just you
Thank you,
just
Dr. Hemant.
just
Yeah.
remember this diagram, and I just like you can do each and every MCQs. Like you can simply diagnose each and every MCQs of your reward. Just remember this diagram.
Yeah. Yeah. Okay. Yeah. Thank you, Dr.
Okay.
Hemant.
So thank you. Have a nice day, guys.
Thank you.
Thank you.
Thank you.
Okay.